Him, but the patient stated that he did not want to be intubated.
And was there any sort of witness in regards to that?
There was not, no.
No witnesses. Okay. And so basically you allowed this person to die by not doing the proper treatment that a normal paramedic would perform.
Objection, speculation.
Yep.
So the cool thing is, so the interesting thing about these types of things, a lot of times, so you don't have, so basically it's just a deposition that you're giving in front of them. So a lot of times you don't have those types of guys that say you're making, right? So it's good, that was perfect. But let's go back to the question. So what do you think?
Can you restate the question?
I totally forgot the question already. Lawyer, what was the question? He allowed him to die?
Yeah, why you didn't act?
Why
on
didn't you
normal
act on the
process?
ability for taking care of this person?
I was going along with the patient's wishes
Okay.
in terms of they just wanted me to use BLS life support measures.
So you're saying that the patient was aware that this BLS, so this person was an EMT as well, so they understand what a BLS care is?
They understood what the fact that they did not want a tube down their throat.
Okay, so a normal,
And then do the-
educated paramedic would have put a tube down this person's throat, and yet you chose not to today. Is that correct?
Going along with the patient's
Is that
wishes.
correct?
Yes.
No,
Sir.
no,
No,
a
that's
normal
not.
paramedic is not gonna violate the patient's.
They're not part of this, it's just you and I in a room.
I am
I
part of
don't
this,
know
I'm a
what
jury of his
society.
peers, yeah.
No, Jerry doesn't get to talk though.
Sir, that is incorrect.
lie.
I was providing the care that my patient requested that I provide him with former knowledge of what I was going to do.
But yet you wanted to put a breathing tube down this person.
I wouldn't say I wanted to.
Did you attempt to educate the patient on the risks associated with not performing the
Yes.
duties? Yes. And what were those risks that the person consented to?
Possible death.
Okay, so you told the patient straight up that, hey, you will die if you don't get this.
I said he could possibly die.
Possibly, but not actually die.
There's no
Right here.
He could possibly die.
But you didn't tell him that he would die.
He might not have.
Well, how could he know?
Might not have had you put the tube in.
No.
Yeah, because if leading the patient, or leading the
No, he
witness.
didn't. No, he wouldn't have died had you
No,
put it
there
in?
was a slight chance that he might not have died.
Slight being like 1%, slight being like 99%.
I can't speculate on that number.
All right. Good job, man. Really? So,
Doc, I see.
yeah, so I brought that up because I've been placed on the stand like that, and it is the most uncomfortable, stupid thing in the world to do, right? They spin everything you say in the opposite direction of what you're doing, and just to get you flustered, right? They get you to that point where you're just like, yes, no, I don't know, maybe, I don't even know, I just
What was
blacked
the
out.
question?
Yeah,
So write
that's exactly
everything
what
down.
happens. It's like, what? Well, see, and that's where I was gonna go with that, and I was just like, oh, we got other stuff to get to, but I was just like, oh, so you mean to tell me that the patient
Didn't
can't
have the
keep track of how
oxygen.
many meds he's taking, but yet can make a decision based on his life that you're not putting the tube down his throat, right? So it creates big loopholes, right? So that's the most uncomfortable thing. So just know that everything that you do, going back to like our discussion earlier, you have to be able to justify your decisions that you make, right? And you try and reinforce it, and you try and back it up with as much witnesses and policies and procedures. Talk to the doc, talk to this person, talk to your partner. Hey, say that a little louder, please, so my witness can hear it, right? And so have those kinds of things in place so that you're not having to be like, oh yeah, it's just me versus him in this room, yeah.
And that's 2 years later, and you have to
So-
remember all that. So document everything.
So if the patient says no and you don't do it, you can call the doctor and it's like, hey, he told me he doesn't want to, but he needs it. And then if the doctor said, yeah, intubate.
Then you intubate,
Okay.
yep. You always do what the doctor says, because now that decision making
Control of that.
goes into the doctor's hands, and then it's like, hey, my hands are clear, clean, I'm good, I don't have anything to worry about, it's all in the doctor's hands at that point, okay?
And the litigation force behind them is bigger than yours?
Do you even need to ask them in the first place, like, hey,
I was gonna say,
if
that's good on
it's not
malpractice.
the patient.
Oh, I always ask the patient. I always
If you-
ask
if you have
old
ability
patients
to-
like that, old COPD patients, be like, hey, listen, if it gets to the point where you are so exhausted, do you want me to take over your airway, put a breathing tube down into your throat and breathe for you? How many of them do you think say yes?
Because they might not come
Not a
off
lot.
the tube.
right? Yeah, so a lot of COPD patients will not come off the tube. So that's where you talk to them and be like, hey, buddy, partner, listen to this. Hey, this is what we got. And if it's something where I think that they may actually buy themselves a tube, I'll actually make that phone call to the doc. Most of the time, you can sit there and you can read the patient and make the determination. Do I think that they are gonna get a tube or not? Like, how close are we on this? A lot of times you can tell kind of along the lines of, yeah, this is gonna be a decision I'm gonna have to make, or I'm probably not gonna have to make this choice. But I always ask them.
And once you transport them and do a transfer of care, the hospital can too, right? Because
Yeah,
it's
because
just a verbal.
your decision matrix is out. That is information that I absolutely pass on to them, though. Be like, hey, on the way here, this person specifically stated they did not want to be intubated. They did not want the breathing tube placed. So then it goes to the doctor to make that determination. They'll look up their past medical history, they'll try and find out other information, and then they make the decision. Sometimes they'll still tube the person, sometimes they won't.
If you are running against a time schedule though, would you, I mean, I don't know how long it's gonna take, we're coming from Benita,
Yeah.
obviously. So we're gonna be 15, 20 minutes away, not knowing how long it would take to physically call the doc, get them on the phone,
Right.
ask them. Would you be incorrect in just tubing the patient because you have no information in hand to not do it?
No, not at all.
So,
Like,
I mean,
because
it's one of those, damn if you do, damn
Yeah,
if you don't.
exactly. You can always justify that you're trying to do the best for the patient, because what they can, you get to the hospital and be like, hey, you know what, this is what this guy said right before we did it, I had no paperwork, I had nobody to witness it, so this is what we did, and then it kicks it to the doctor, who says then, okay, well, I'm gonna look up past medical history, yep, this guy's got terminal lung cancer, this is what's going on,
And
we're
we
gonna
know
make that
he-
determination, we're gonna extubate him, and we're gonna see what happens.
Because it doesn't seem like me, I would hesitate to put a tube in this patient's throat with no documentation and no witness.
Yeah, no, it's, the witness is the big thing, and that's why I took your witness away, as you said, hey, I'm gonna open up the slider, because that's exactly what you wanna do.
Yeah.
Phew. Hey, say that louder for me. You do not want a tube. Confirming that. Say yes if you do not want a tube placed in your throat. Yes. Hey, you hear that? Okay, cool. Right? So it's that kind of approach, because you absolutely want that extra witness to help you make that decision. Especially if they're getting close to the point where you're just like, ooh, we may actually have to tube this person.
And that makes sense. I mean, okay, so now if you do have your partner as a witness.
They call both of you. Yeah, we both heard it.
still have no paperwork.
You have 2 versus 1. You have 2 people saying, yeah, this person did not want it in their wishes. It makes it a lot, it's not clean, it's not completely clean, but it's a lot cleaner than it was beforehand.
So ask that question early when you have the ability to get permission.
But you brought up that point of like they couldn't even remember their meds, how can they make that decision?
Right.
But they were completely
So
oriented.
that's
I
where,
forget a couple
that's-
meds every day is like different.
so it all comes down to your ability to be able to explain and understand whether or not they understand what's going on.
Well, also in this case, the patient said that he was a former paramedic, so he also knew.
Oh,
Yeah.
Case solved now.
Done.
So-
Peace. I'm out. You guys do so good at listening to every word I say, but yet
Can't
lying
read
none
the
of it.
slides. It's so easy.
What did you say?
That was.
You didn't allow us to help Noah.
No, that's good. Yeah, so it just becomes one of those judgment calls, try and get as much support for your decisions as possible. How often should files be taken on this person?
5
Like
minutes.
Constantly.
almost constantly, like constantly, right? Yeah. And then we try and help when we can in the long run, okay?
It's a great shame. He's worried your slides.
Alright, okay. One last little bit of assault, sexual assault. Okay, so sexual assault. You guys are gonna respond on these. Are most of these life-threatening emergencies? Right at the time when you have the call?
Not in
Most
this
of them are
part.
not. Are there some that are? Are most of them not only the sexual assault, but why is it usually become a life-threatening emergency?
There's a physical assault.
The physical.
There's a physical aspect to it.
There's a physical aspect to it where there's more than just the sexual portion of it, right? It becomes the actual full traumatic event for basically the entire body, right? Head injuries, subdural bleeds, unconsciousness, unresponsive. You find somebody down in the ditch by a location, and you're there because the cops was like, hey, this is what we came across, and then you have an unconscious person, right? And so these are the cases where it's like, what is our priority in this situation? Let's say they're the unconscious, unresponsive person.
Airway,
Not
airway,
Not
airway.
preserving evidence, but to save the patient.
try and do both.
But our priority is the patient.
Yeah,
Give me a little more, Noah.
like, I mean, you're gonna try and disturb the scene as little as possible and only, fix things on the patient that are life-threatening and that you need to address.
So you're only gonna fix life-threatening, huh?
Well,
Would you like to take the stand again?
no,
I'm just kidding. Yeah, Melanie,
Document everything that you
Oh.
find and your scene size of.
this
everything.
paperwork is gonna be one of your longest charts that you will have to do.
Not cutting clothes.
And then.
So I was just gonna say, so let's talk about, so you have an unconscious, unresponsive person found off the side of the roadway, they suspect that there was a sexual assault that occurred, and now you're going to, what do we do with trauma patients?
Take all their clothes off.
Cut the clothes off, right?
Mhm.
Put the clothes in a.
So do we have a different thought process now as we're doing that?
Yeah.
Yes, because you guys are good paramedics, right? You guys aren't the cookbook, we're gonna do it exactly this way because it's a trauma every time, because you guys are smart, you're thinkers, you're gonna do things a little bit differently, right? So the idea with sexual assault is you take all the clothes and you bag them individually, right?
Big bag.
That's why we carry tons and tons of biohazard bags, right? So as you cut things off, what are we avoiding? What types and areas are we avoiding to cut?
The rips or tears. or-
Rips, tears, what'd you say?
Oh, never mind.
You need to have fluid
Said-
on,
Any-
What's that?
blood or semen.
Okay.
anything.
So I have a question. So I've taken a rape victim in, and the police told us to bag everything in paper bags and not.
We don't have
biohazard
paper bags, so the next best thing is the plastic bags. So yeah, we don't carry paper bags. If we had paper bags, it'd be great, but we don't carry paper bags. And why do we not carry paper bags?
Because we
They
just
don't
know.
last.
There's a
To
pointless
get wet. and
Because
most-
what do most of our stuff have that we bag?
blood.
Blood.
Blood, wet stuff, and then
Ooh,
it's dripping through the bag. So that's why we don't carry paper bags. But if they're there and they are supplying us with those bags, then absolutely it can go into those bags.
And it like affects the, what does it affect? I forget to explain it, like the evidence somehow.
The plastic.
Yeah.
Yeah.
Holds in the moisture that
It
reveals
has, yeah,
gas.
Do you
same
need
with
to
moisture.
Oh,
keep
okay.
the clothes with
The
you
paper lets it
or
out to where.
get into a
If the police officer's there, then you can pass that information, because then what does that eliminate?
Chain of
you from?
custody.
It eliminates you from the chain of custody, right? Is this one where the potential you're gonna end up on the stand?
Yes.
Okay. So with this being said, okay, so are we gonna treat this person like a normal trauma patient?
No.
Other than the.
Yes.
Well,
When it needs to be.
But with a softer voice.
Yeah.
Right, but this person's unconscious, unresponsive, okay? Are we gonna treat them like a normal trauma patient?
Yes.
Yeah.
Yes, all the treatment stays the same, right? We don't change any of our treatment because of what has occurred, right? Our thought process, though, so when I say we don't change our treatment, if we're cutting this way with our scissors, we may go like this as we cut around holes or something like that, right? But if we're going to intubate somebody and the person needs to be intubated, are we gonna withhold the intubation
No.
because
No.
there's some potential evidence in the mouth or something like that?
No, because it's life over limb.
Exactly, right? So it doesn't change a lot of what we are doing in the treatment portion of it, in regards to the life-threatening, critical injured people. What it does change is it changes for the people that, don't have the life-threatening emergency, but were there because the event occurred, and now we're taking them to the hospital, because, maybe they have superficial wounds, maybe they have, wounds that need to be taken care of, but they need to go to the hospital, right? Need to get them removed from the scene or the situation, right? Super uncomfortable situation, and these are the ones where it's very hard to have a conversation with the patient, right? Because they just went through something traumatic, and now you're trying to OBQ or ST the heck out of this, right? Is that the best thing to do?
No.
Sample history? What is the best thing that we can do for these situations?
Make them
Make
feel
sure
safe.
they're comfortable.
Yeah.
So, say it again, Amanda.
Make
First
them
thing,
feel safe.
safety first, right? So you're almost, I don't wanna say that you're taking, these individuals and turning them into children type of thing, but you know how we approach children, we approach them differently? Same kind of approach, like, it becomes hey, we don't need 12 people going over to take vital signs and do all that stuff. Same kind of thing, right? Like, if they connect with one person, everybody else can hang back, right? And so you have that a little bit softer approach for people that have been through traumatic events like this. Does that make sense? So don't everybody rush in and do your thing, okay? Definition of rape crime, of forcing a person to submit to sexual intercourse against their will. Rape is also considered a sexual assault. So you have multiple different things that people will present. I actually had to look up what truancy was. I forgot what it was already. That's how.
Isn't that when you skip school?
Yeah, skipping school. Yes, that's it. Cool.
Was it something else?
What?
Did you find a different
No,
definition?
no, that's what it was.
Oh,
But it was, I got a small vocabulary,
Okay.
okay? So like I had to look up what it was,
Is it trucky now?
right? I grunted on like I do a lot of pointing. I'll be like,
So you're mine?
right, that's how I communicate now, right? Okay, so different types of presentations. A lot of times we're not going to come across these. We're coming across the acute incidents, right? But let's kick it back to, remember our child abuse people? You're there on a welfare check, right? So now you can start to put some of this kind of information into, okay, so yes, we have physical abuse, but we also have the sexual abuse possibility where we start looking at some of these presentations, right? Is it normal for kids to get into drugs early? No, not usually. Usually there's some sort of either lack of supervision or something associated with what pushes them in the direction, right? How about like suicidal tendencies in kids? But I mean, it's a cool thing, right? Usually is there, the person that starts things, is there some sort of underlying event or behavior that kind of starts the trend, right? And then that's a cool person, and then everybody else wants to be like the cool person, and then one thing leads to another, all right? Withdrawal tendencies, I think we kind of talked about that yesterday. Nightmares. So, do you want to ask people that have been through some of this kind of stuff if they're having nightmares about this kind of thing, or do you think that they're reliving it every time they do? I tend to avoid these types of questions in regards to nightmares and stuff like that, because I don't want to cause people to have to relive the situation over and over and over, just so that I can get my paperwork right. All right, so like if a sexual assault takes place, what types of questions do you think I'm gonna ask?
Having trouble sleeping?
So let's say this is an acute incident, right? I show up, here's the individual involved, they say that they were sexually assaulted, the cops are there, they want a medical eval.
Do you have any pain anymore?
Okay, pain.
What's your name?
Huh?
What's your name?
Oh, it's Chris, thanks. I appreciate that. Okay. I wasn't judging you, right? Because I probably would, so to be honest with you, I asked the name from the cops before I even approach, so.
It gives you, though, a way of them knowing.
Yeah.
That you
I introduce
actually
myself,
care.
right? Introduce myself, hey, my name's Chris, what's your name? Hey, how are things going? Do I approach it that way? Hey, what's going on?
How's your day going?
What's up? No, you don't have that approach, right? It's like, it brings it down, you come down, you kind of bring it down a couple of notches, and you be like, does anything hurt, right? Do you have pain? Do you have injuries anywhere? Do you have anything? Oh, never mind. Can't go there with you guys. Focus. And then, so it's just that type of approach that you take with individuals that helps you kind of go down that question and answer approach. Okay? So, pain, injuries, what else? What else do you want to know? Anybody?
Would you
You
like-
guys are on scene of.
Would you like to go to the hospital?
I don't know. Do you
would-
think I need to go?
Well,
You have to, yeah, I would think you'd have to.
you
to
don't
do anything.
have
Oh,
to,
Well, I mean,
No,
but-
you're in
Good,
control. You
sorry.
don't tell them to do anything.
Yeah.
Right.
That's not what I meant.
but it's
Yeah.
it's more so. Would you like to go and talk to a special nurse or
Especially.
Special.
wait,
They're special.
you know, a rape nurse, what's
Is
the?
that right?
No, I'm trying to think of the
geez.
words.
I know, right? See,
Yep.
so this is what you can't
Social
do.
worker.
This is what you can't do. Is you can't start
Right.
just throwing out
A
these,
saint is
these
it a
crazy
sane
words
nurse?
and stuff and be like, ha, like you have to have your shit together when
Right.
you walk up there.
There's a lot of assistance that we can provide here, but
Ugh.
there's a lot of assistance in the hospital.
Yes.
I'd like to go talk to somebody there.
Yes, no, I want to talk to you.
Okay,
Okay.
if you want to talk.
No, you don't want to hear that. We are not good at that. Like, well, I take that back. I am not good at that. No, I do not want to talk to you about what just happened. I'm as uncomfortable as you are. Ah, it sucks. I don't want to talk to you,
It's like,
but I'm going
okay,
to.
if you want to talk, do you want to talk in the ambulance?
Oh, thank you. Privacy, privacy, privacy. right? So, like, where are they normally at when you get there with a cop?
Depending on what.
Living room, in the street, standing there next to the cop car, in the back of the cop car, right? So then what do? You open up the cop car and then you're hanging over the top asking questions.
Do you,
No.
but would you start even before asking a bunch of questions, like introduce yourself and like whether or not they feel safe? Like where they're at that moment and if they want to go to another safe place or something?
I wouldn't necessarily start it that way. Like in the first one or two questions, you're gonna get a sense of how they're feeling a little bit, not how they're feeling, like how they're presenting, right? And so you just buy in that because you don't want to just be like, hey, you wanna come with us? You wanna go get in the ambulance, be in a spot over here?
Right, I wouldn't ask.
So you get, so you get that little rapport with the person and figure out like, hey, okay, it's like, are you hurt? Are you injured? Hey, is anything bothering you right now? Probably a bad question to ask, right?
I mean, do you acknowledge the event? Do you acknowledge the situation?
Absolutely.
Yeah.
That's what I was
Absolutely.
curious.
Yeah, no, absolutely, but at the same time, like, you need to know what happened,
Yeah.
right? But you don't wanna be like, so, tell me exactly what happened,
Yeah.
right? Like, because by doing that, what does that cause them to do?
Relive it.
To relive it all over again.
Like
Because
there's
Is it gonna change your treatment for them to relive it over again?
all you care about is things that are going to affect their treatment.
Right, so I'm gonna ask very specific questions. Did you get struck in the head? Did you get hit anywhere? Were you struck with an object? Did anything like that happen? Was there any sort of knife or devices used? Anything like that that could affect life-threatening things down the road?
Right.
Like if all of a sudden you go into a seizure here, and I'd asked you, were you struck in the head? You're like, yeah, they hit me in the head with a 2x4. It's like, what am I thinking now? If they
Head
go into
trauma,
a seizure,
ICP.
I see.
right? So that those are the kinds of things that I want to know
Medications
to,
given, yeah.
to get to that point where it's like, okay, I'm gaining the rapport, I'm proving to this person that I know what I'm talking about, medical wise, that's why I'm here, to make sure that you are medically okay, physically okay. I know that you're not emotionally okay, and I'm not good at talking
Right.
about the emotional part of it because we have zero training. You guys have zero training in dealing with the emotional crisis associated with these, right? And then you have this awkwardness of, yeah, tell me exactly what happened. They start to relive the whole thing, and then the emotional breakdown happens. And then what do?
Handle it gracefully as professionals.
Yeah, what do you say? What do you say? Do we embrace? Do we embrace
Yeah,
them? Like,
sometimes
do you want?
silence is the best.
Like what? Yeah, silence is the most awkward, horrible moment in the back of the ambulance in these
But
situations.
sometimes it's the best option.
Oh, it's horrible though. Like I do everything in my power to not get to that awkward silence thing.
They
Oh.
fill it with even awkwarder.
Awkwarder.
Conversation.
Questions?
What?
More awkward questions. Sorry.
You don't ask an awkward question.
You don't. Yeah. See. So see, you try and avoid doing what Mark did here, right? So he started throwing out all these other things. He's saying rape, and he's saying terms that are like terms that he's stumbling over his own words. So you want to have your stuff together when you come up. So you want to have those candid questions that you're just like, this is the information that I want to know.
I don't need to know
That
everything.
allows me to kind of stay away from those until I have to ask those questions, right? Like what they were saying is like, I'm not going to avoid the questions. Eventually I'm going to get to them. But what I want to do is I want to break this little ice thing, this uncomfortableness, because it's like, I know they don't want to talk about it. I don't want to talk about it. They don't want to talk about it. They don't want to relive it. But yet eventually we're going to have to get there, right? And so trying to come up with that slow transition to get there. Are they dying in front of you? No, not necessarily. But I want to know, hey, were you hit in the head? Were you struck with this? Did this happen? Because you have the potential, in my head I'm thinking, you have the potential that you could suddenly change your medical condition, trauma condition, and then boom, we got to fast forward, right? But I have that information then obtained, right? So that maintains that professionalism in your question, medical profession, that you're obtaining that information, getting to that point. It's like, oh, hey, let's get you in the back of the ambulance so that we can check you out, okay? Get some vital signs on you, get this cleaned up, whatever you need to do, put some bandages on, stop some bleeding, that kind of thing, right? And then when you get in the back, like you're there in the back, right? So I will always send 2 people in the back of those rigs every single time, right? Most of the time you try and go same sex. It's very hard in our profession when we have like 6 female firefighters on the entire department. And so there are those situations where it's like, okay, well, 2 people are going in the back. And you just be like, hey, this is what's happening. It's like, I don't even give the firefighter the option. I'm be like, hey, so-and-so's riding with you. Most of the time I go with them too, because then I just sit in the airway seat and I just listen, right? And I steer people away from certain questions or conversations, like, don't wanna go there, don't wanna do that, right? Because they are having a hard time coming up with the right questions to ask, because they don't want that awkward silence, so they start running through the OPQRC sample history, right? Guaranteed every time. And so it's just that kind of approach that you take, right? Eventually, you're gonna have to get there as well, all right? Make sense?
How do you ask it? I don't understand how you're gonna ask that question. You're just gonna say, tell me
Yeah,
what happened?
yeah. And I'll be like, so, just so I can get the story straight, so I can pass it on to the nurse, who's gonna be taking care of you, can you tell me what happened, right? And I'm not gonna ask them for more detail than what they're going to give me, right? Whatever they say from that point forward is what I will take. I'll take that information, relay that to the nurse, and then I'll take the physical findings that I came up with the vital signs, and relay that to them.
And if they don't wanna tell you?
And if they don't wanna tell me, I'm totally okay with that. And so that's, if they say, I don't wanna talk about it, I'll be like, okay, I just have a couple questions just to make sure, that medically you're gonna be stable. I just have to know questions in case anything changes between here and there, where you struck in the head, did this happen, did this happen, did this happen, right? So you get those things to be like, okay, I don't see anything on the back of your head, it's like, they're like, oh, no, I got hit in the back of the head, ooh. Am I gonna want to palpate the head then? Yeah. So then you ask for permission, right? Hey, is it okay if I feel your head to make sure that there's not something significant that we need to address, right? And you say significant so that they know, this could be something bad, instead of, hey, can I just feel your head, right? I hear that all the time. It's always like, hey, can I feel your head?
Why?
Do you realize what I just went through? It's like, hey, can I feel your head in case there's something significant there that we need to deal with and address? Oh, significant? Oh, okay, yeah, don't let me die, right? So it's that kind of approach that you take. But the question is like exactly how, I would present it exactly the way I just did. So just to get the story straight, so I can give that information to the nurse that's gonna be taking care of you, would you mind telling me what happened? You don't have to, it's totally up to you, just so that we can make sure that we get the information. Sometimes they will, sometimes they're like, I'd prefer not to talk about it. I'm like, I'm totally okay with that. Is there anything I can do to make you ride more comfortable? Is there anything I can do to make you feel safe or anything like that? Yeah?
How's your radio report gonna sound?
Are we out here at 11?
11.
Class starts at
11. 11? Okay, cool. Radio report. So, gosh, this whole Sarah thing is just making radio reports go obsolete. But it would go something along the lines of, so we were running Act 2, round code 1, EJ, 5 minutes on board. We got a such and such year old patient, was victim of a possible sexual assault. Patient denies any loss of consciousness, was not struck, no obvious signs of trauma. Patient's coming in with PD in assistance. Vitals are this, no physical complaints at this time. It's very, very vague. You're not saying this person was raped, you're not saying any of that stuff. Sexual assault, they kind of get the gist of it. With Pulsera, it would just basically, Pulsera is just the new app that we're texting everything in. I would just simply put on their sexual assault and then the vital signs.
And any major trauma.
Yeah, and then if anything, major. Okay, cool. All right. Peace.